welcome to In the Loop, where we explore the big questions facing our health and care system. I'm Niall Dickson, one-time BBC journalist and health leader, and my partner in crime is the one-time NHS Chair and ever controversial writer and commentator, Roy Lilley.
Good afternoon. Good evening.
Our guest today is certainly worth listening to. It's Richard Meddings. He recently stepped down after 3 years as chair of NHS England. Richard's an accountant, he's been a banker, including chair of TSB, and he was a non-executive board member of HM Treasury for more than 7 years. He was appointed as chair of NHS England for a 4-year term, but with the new government, he stood down a year early. Now, as many of you will know, Richard's departure coincided with the Prime Minister announcing that NHS England itself was heading for the chop, to be merged back into the Department of Health and Social Care, with the ambition to cut duplication and 9,000 jobs. And in addition, the relatively new integrated care boards have been asked to cut their workforce by a further 50% on top of earlier cuts, meaning 12,500 more jobs to go. So, Roy, I'm sure we'll want to explore with Richard what he makes of the decision to abolish NHS England. He's in an unusual situation. He's a private sector outsider, as it were, brought in to head the NHS in England. And I'm guessing that that will mean he has a different perspective from many other NHS leaders.
I'm sure you're right. I mean, I do know from conversations I've had with Richard, when he took the lid off the tin marked NHS and had a look in, he was horrified at what he saw in. And he went from being horrified to being full of admiration. And I must say, looking back on my own experience coming into the NHS from business, I sort of turned up in a pinstripe suit and everybody thought I was going to sell the hospital to Sainsbury's, that kind of thing. And, you arrive all cocky and know how to run everything.
What was it, Tesco you actually sold out
to? Exactly. And you come with a set of values, you come with how you've done things, you come from an environment where you're the boss and what you say generally goes, and you say jump and people say how high. What I found in the NHS, and I know Richard did as well, is not like that. It's nothing. It's much more consensual. It's much more thoughtful. There are people working in the NHS who are much cleverer than you are, much brighter than you are. They do much more complicated things you'd ever dreamed of. It's a much more complicated thing. It's, you press a button here and it's a fortnight before a light goes on there. It's very, very different. And I had to acquire a whole different management style, really, to try and work in the NHS. And I'm pretty sure we'll find that Richard Meddings had the same experience.
I think it's fair to say that picture of bringing people in from other sectors has been a mixed one. Some have been successful, but many have actually fallen, not just the private sector, but from the military, from all sorts of other walks of life. The NHS is a strange cult.
It really is. And it's right. It's funny you said that. Who was the colonel that came in and wrote the management thing recent? Messenger, wasn't he? And he's a nice enough chap. And he wrote a report in the context of his years of experience working in the military, which is nothing like working in the NHS. And his whole report, as well intended as it was, it just completely fell flat. It's lost and forgotten on the shelf of all the other reports that have been written about the NHS. And it's a shame, really, because there are things that people from outside can bring in. But I can't remember anybody that came in from outside, in inverted commas, and actually changed anything on the inside of the NHS. My experience has been you come in the NHS and the NHS changes you. It's certainly changed me.
I hope we'll also get from him his experience of what it's like to chair an organisation like NHS England, because it's quite unusual, again, to get this glimpse quite recently from somebody who's just stood down in good odour, if I can put it that way, and is therefore able to just tell it like it is. What was the experience? And you said he obviously goes through that, presumably a degree of alienation when he first comes in and how he adapts to all that. But I still think that background from the private sector will give him a perspective that perhaps some of us who have lived with the NHS alongside it for such a long period of time, you can get too close to something.
Let's see what he says.
Well, welcome. We are joined by Richard Meddings. Richard, when did you first learn that NHS England was going to be abolished, and was it a surprise?
It was a surprise, although I would say that certainly the board, not in its formal board meetings, but in reflections amongst ourselves, had thought that it was quite possible that would be absorbed into the department, but we thought it would be in a second term of the government, not the first term. It was a surprise it came suddenly. So actually, I personally was told actually on the morning of the announcement.
So, no run up to saying why this was going to happen, or
No, I don't believe so. And I think others will know more closely how sudden that decision was made. But like all decisions, actually, they may have a period of sort of long gestation and then they sort of accelerate towards the decision moments. I mean, and essentially it was a political decision. I don't know when it was first mooted or being debated in the political world, but I do believe it was quite an accelerated, sudden decision over a matter of probably relatively few days. I don't believe that anyone in NHS England, even the incoming new team, knew very long before the announcement.
I don't think anyone could have known, because if you look at what Streeting said before the election and just after the election, he said there won't be any big reorganisation. And he actually said, as a quote somewhere along the lines of, I'm not going to waste taxpayers' money or my time in trying to reorganise the names on the office doors, I think he said, or something like that. So I don't believe they came into government wanting to do this.
And in the end, I really don't think the structure particularly matters. And I better quickly develop that. As long as the process of that abolition or merger does not wash over into impact on patients. And for me, that goes to a different question, which is, as you do that, it's really important that you execute well on the reshaping and the restructuring and the headcount reduction. Because actually that week of the announcements was quite a week, because we started on the Monday morning with an announcement of a 50% reduction in the headcount of NHS England, followed on Wednesday evening with an announcement of a 50% expense run reduction in the ICBs, which largely equates, I think, across into significant headcount reduction. And then on the Thursday morning, the abolition of NHS England. I think it's much more important that as the department and NHS England combine and people really do the fact-based work around what does NHS England actually do and for what is it responsible, that they therefore understand the deployment of the headcount. And before one goes for sort of really big targets, understand why you go for targets, big targets, really to incentivize and catalyze behavior, it's really important to understand for what is it responsible.
So are you sympathetic to the idea that the NHS has got enough to do in terms of its challenges already, that this is just a massive distraction?
I'm concerned that it will be a distraction, but as I say, the importance is the execution of it, that it doesn't actually cause disruptions. In many ways, you might argue, and I've heard it said, that actually the expense reduction, let's pretend it equates to a 50% headcount reduction. It probably won't be quite that, but an expense reduction that's significant. I mean, that's one or two steps closer to the patient. So I'm more concerned that that's done effectively. In terms of NHS England, I mean, these are the important facts. That yes, there is bureaucracy. There's bureaucracy in any organisation. It's really important to keep pressing down on it. That NHS England in the last 2 years has reduced from 24,000 headcount, actually, as I was leaving, to 13,200. So the 15,000 is the establishment number. That's the number of roles, but it's actually 13,200 people. So it already had carved down over 10,000 roles. Which actually, if I was making an aside comment, I wholly agree with the government initiative to debureaucratise and look at more effective and efficient running of the, quote, civil service. When the initial target of 10,000 headcount reduction out of 550,000 was suggested, it looks positively anemic. NHS England on its own had come down by 10,000 over a 2-year period.
That does show the capacity of the NHS to build all these jobs in the first place, doesn't it?
No, because I think what you've got to look at is what was happening to do that. So we had also created ICBs, and they had emerged at the same time as we merged with NHS Digital and Health Education England. And it was part of a multiple level strategy. Part of it was to debureaucratise and reduce the burden of the centre. Part of that was to get more cost out into the front line, but it was also to allow for greater devolution to the 42 ICBs and to pass not just broad commissioning, but also increasing proportions of specialised commissioning, also allocated actually to the ICBs. So actually they were being empowered and we were pushing more of the activity and the governance oversight through into the ICBs.
No, but my point was that the NHS had built all these jobs up in the first place.
No. So they came together because it merged NHS Improvement, NHS X, a very small technological institution, NHS Digital we'll come to, and Health Education England. Now, when NHS England was created in 2012, it was NHS England largely. And the reason it gets bigger is because actually, post July of 22, it is then given responsibility for Health Education England and NHS Digital, the two big pieces, as well as all the work it does interfacing with Whitehall and managing the numbers down through the system. A lot of those roles are taken out of NHS England and devolved, and the responsibility shifted. So it isn't as narrow as you created lots of extra bureaucracy. It really isn't, because those roles are being pushed out and down along with a devolution into the system. The important point I want to make about the restructure, which is why I don't really care, I do care, but I don't think the structure of itself matters as much. It is that NHS England runs and oversees, which it didn't do before July 22, 270 live running systems, which connect to 26,000 organisations who themselves are running 44,000 live IT systems. And NHS England, in July 22, took over responsibility for running all of those. They also took responsibility for overseeing and liaising with all initial and continuous medical education, whether it's medical schools or nursing colleges or the universities. So that also is absorbed into NHS England. And those two broad functions still operate.
I kind of get that. What concerns me more really now at the moment is the fact that we've got hospitals who are running around making people redundant. They're just cutting headcount to satisfy what's happening at ICBs. I mean, Southampton have announced a lot, Nottingham, and there are others who are announcing redundancies. My worry about that is who's going to do the jobs that the people are leaving behind? How are they going to cover that? And how complex running a hospital is. And the fact that there's no rationale behind it. To have a rationale to say we've got to sack people because we've got to save money is fine. Okay, that's a rationale. But the actual rationale behind what work needs to be done, who does that work, what sort of people do we want to do that work, and what technology and whatever it is that they need to make that work work. None of that. This is not about reorganizing work. This is about reorganizing the workforce.
But we did see, and we must be careful, all of us, for some sort of a binary discussion that this is good and that is bad, because these things are all quite textured and they're different wherever you go. So you go to different providers or different hospitals, and they have different shapes and different needs and different workforce. And when you look at the rate at which they grew their staff, particularly in that hugely, wildly disruptive period of the pandemic, when you do see the headcount growth that actually occurred from the pandemic and in that period, where actually we'll all absolutely justifiably compliment people in the NHS for the brilliant job they did, but actually a lot of the muscle memory and the controls went away to focus on that singular pressure point. So we did see quite a significant growth in headcount, particularly in our provider network. And actually, one of the things that's been happening over the last 2 or 3 years has been pressing down, with support of the boards of those trusts, has been pressing down on quite a lot of that hiring, and on bank and agency costs. And it shouldn't surprise us, should it? That actually, if you just take all the controls off, because we're going to head hard for a really urgent, in that case, pandemic, and those costs have grown, and some of that muscle memory about control has been weakened, that actually it will take some time to reverse back out. Now, at the other side, we need to be careful we don't cut into bone, but there was clearly a significant growth in the headcount in that period. And Neil, you used to chair in this space, and you all have seen it, and no one's to blame for it, and it's not a bad thing, but you can understand why and how it happened. So we've got to drive those unnecessary costs and that unnecessary headcount out, and it's really important that we do that.
I do think there's a crudeness to saying clinical jobs are fine and non-clinical.
I agree.
Because then you find the non-clinical person who's supporting the clinical person, then the clinical person is not able to operate in the same way.
I think the NHS is over-administered and undermanaged.
The Damascene report says that.
Yeah, I think it does.
It makes it really very clear. You're an eloquent advocate for the NHS.
I'm a convert.
You are
like a religious convert, and even more than.
When you landed from outer space into this one weird planet called the NHS, what did you think when you sort of landed and looked at the job? What was your reaction? I mean, you took the lid off the tin and looked in and thought, what?
So there's one actually it's like sitting in the boardroom of a big corporate, but where the shareholders in the room, which of course isn't how private companies run. And so actually that weekly interaction with the shareholder and the very frequent requests coming from the shareholder for new things, sometimes with money, sometimes
The
not.
shareholder being
The shareholder being the government, essentially being broadly the government, but for this purpose mainly the Secretary of State. So the intensity of the engagement, which actually I've always thought that much of the system didn't, even if they knew of it, they didn't have a real understanding for how pressing it was.
It's not supposed to be there, is it? Andrew Lansley set up NHS England as an arm's length body, and ministers weren't supposed to interfere.
But as you know, I had 6 periods of different Secretaries of State in 3 years, and each time the Secretary of State changed, all the ministers changed. And I do then say, and I mean it, that if you go into politics which you want to make a difference, I can't think of many departments to get asked to be a minister in better than health where you think you can make a difference. So in come the ministers and they have ideas and stuff they want to have done. And of course, the multiplicity of health need in our society is massive. So actually there's lots of stuff they can get involved in. So actually what the system doesn't always see is the intensity of engagement that happens from above into NHS England. And I think that was one surprise. But the thing I misread most was demand. So I thought that it's the change and the fast growth in demand was the thing we had to get at. And I thought that's the real priority. What I came to realise, and I'm probably wrong, by the way, where I end is to say demand is really important. But for that, we need different help and a very different approach by society and government, if we're really frank about it. The real thing that surprised me was capacity. And I was very, very surprised. The thing that's most striking are those quotes where, relative to population size, we have 1/3 the beds of Germany, half the beds in our acute of many of our OECD partner countries. We have less than half the average diagnostic capacity, echo, MRI, CT. Our workforce had 100,000 vacancies in it. I think that's the capacity. And then Darcy captured it, didn't he? He captured it very well. But again, no surprise to any of us. But what he pointed out was society is getting sicker, and it's getting sicker and is being looked after by an underinvested capacity. And that capacity is being essentially overwhelmed. We don't think differently about it.
But if you look at the funding, we don't spend as much as Germany or France, but we do spend more than lots of other countries.
We're about average, aren't we? We're slightly below average, I think.
So have they got massive capacity problems as well?
They do. You can look at lots of other countries and look at their health systems and you'll find, it's better there and better there. But actually, you go in there and actually you do find there are real deserts in virtually every other country that exists in this world. You got a casualty or ED or A&E, and you got, in many cases, the same sort of pressures piling up. And that shouldn't really be a surprise if we actually look at what's happening in workforce supply chain. We're now all recruiting hard into the same relatively small number of countries to get international staff. On GDP, it's actually this media trope because it's 44% of government, that's a government spending, is on the NHS. But if you look, the words are 44% of day-to-day spending. And to get to that number, they exclude pensions, welfare, interest on the debt, defence, because they're not sort of day-to-day, apparently, and the health services. So what did government spend last year? 1,250 billion, about. And what did they spend on the NHS? 190? They're actually spending about 16% of government spending is on health of the nation. I don't think that's out of line.
No, I don't think it is. I think I have a lot of misunderstanding about it. And when we spoke to Paul Johnson, one of the things people find very difficult to understand is the government announces, we're going to spend X billion now more on the NHS, so it'll all be fine. And that's always overhyped. And as Paul pointed out, even the extra that's been put in will very quickly.
Well, and the annoying thing is that when they make announcements, they're announcements that generally don't make any difference either. What were your relationships like with the Secretaries of State? How do you manage those relationships?
With every one of them, they were amicable. The frequency of my personal engagement varied across, depending on which particular Secretary of State we're talking about.
2 or 3 times a week?
No, nothing like that. Formally, once every 3 weeks would be the most frequent for me to go in. But I was about to say, but the team, the executive team, is going in at least weekly and probably for 2 days a week or so.
Well, Steve Barclay changed the seating arrangements.
He went open plan. It was quite an interesting move, actually. He went open plan. He had the ministers sitting in an array around him, and then sort of one layer back where the Director General and so on was sitting there. Actually, you see that in a number of private companies, and just tries to change the rhythm of engagement and the openness.
Is there an exchange, an interchange, or are there sort of...
It can work. For me, I don't think there's any one method that always works. I think actually what you need to do is change them every so often and make people think slightly differently to break habit. So I think open plan was perfectly sensible for a period of time. But the danger is, of course, you can't put everybody around the table. So if you make an open plan in one room, you're breaking the link somewhere. So if the Director Generals are sitting around the ministers, they're not sitting with their teams directly. So you've got to choose where is it you put the communication line.
But it must be very frustrating if you take the executive team, the amount of time you're saying that they're having to spend doing. So they're spending their time, as the NHS generally has too much problem with, which is looking up instead of looking down or looking across.
But the world is, if we sit back, what a world we're in. I mean, it's a very interesting world, isn't it? Because I sit and I look at the number of different views that exist on what people think should happen in the health service, range from all the think tanks and all their work, ranging from NHS Assembly to NHS Confederation to NHS providers, to the non-health think tanks, but the think tanks, to all the single issue lobby groups, whether it's Alzheimer's Research UK or Cancer Research or Macmillan, all of them lobbying hard, and they're lobbying into ministers. And then you've got MPs reacting to what's going on in their local areas. The world we live in is a complex area, and health is so fundamental that it shouldn't surprise any of us. At the apex here, in the department with ministers with whom the buck stops, they are being accosted by lots of requests. And then what do? Just ignore it? Or do they give them into us and debate them with us and say, what can we do? I don't think we should say it's a problem. It's just, I think we need to understand that that's the way the system operates. And if you've got an independent arm's length body whose job is operational execution, which is what it is, they have to deal with the fact there's a huge pressure coming on those ministers to look at other things all the time and they try and decide. And then there's an engagement, well, if we do that, we can't also do this. If we do that, is there any money to fund it? And so that debate is continuous. And then actually the NHS does the same down through the system into the providers and into the primary care and into pharmacy and so on.
So we're all waiting now with bated breath for the 10-year plan. What's going to be in the plan?
It's going to be 3 shifts, we know that.
Prevention and innovation and hospital community. Yeah.
And there's not anything in there.
There's nothing new in that.
There's nothing new in that. But they're all nothing new, but they're all sensible. The question is, what do you prioritise and choose to do first? And for me, I'd always have 3 chapters involved in a 10-year health plan. One goes back to that capacity realisation. It's this idea of a separate, proactive engagement for frail and elderly people.
Well, you're saying carve that out.
Yeah, probably a particular service. I don't think you necessarily call it the platinum service or something, but I think what it requires is a more proactive engagement. So rather than having patients, citizens turn up as they think they need to, or as their helpers suggest they might, we proactively engage with that cohort. Because as you know the stats, it's 25% of the population is over 65. They represent 50% of admission to hospital, but they're 74% of bed occupancies. And I think the biggest negative impression people have is people waiting and queuing in ED, often very elderly, on trolleys, waiting to be admitted. And that just real problem with flow and ambulances queuing up. And that's because our capacity is so constrained. Again, the stats, and Neil, you know them, back in 2003, 144,000 GNA beds. Today, 98,000. So we've cut a third of the beds in our acute hospitals while the population has grown 15% and aged. Even with all the money in the world, which we haven't got, it takes time to build capacity. So the way you have to think about it is, how do I deploy the current capacity I've got better? So who's using it? And who's mainly using it are older and frailer people. So if you then say, well, let's think of a proactive engagement with that cohort, not necessarily a separate offer, and you change geriatrician job plans in hospitals so they spend more time in the community. You do truly make primary care the nodal point. You build virtual wards, which are quicker and easier to build. You make sure that when you bring people forward, you have a range of different health and social interventions for them, but you proactively go after that cohort of the population. And by doing so, one, they get better treatment, I hope. But I'm looking at it as an industry problem. Our issue is our capacity is insufficient for the demand and we're being overwhelmed. And the way to do that is to create capacity within that capacity. And I think you can do that proactively by going after frail and elderly people.
Sweeting has just been talking about, hasn't he, the Brazilian
The favelas.
example, yeah. But that is about recruiting more people.
I mean, I don't know if that idea works. I think the good thing about that, but whether it would work in the UK.
Well, it won't work here with the people we've got. It won't work here with the way the GPs are structured.
No, but the good thing about it is I think it is really important that such is the urgency that we're willing to think really radically. And if the Secretary is willing to think really radically, and that's a really good thing.
But I'm just thinking about the practicalities, in the current environment where the headcount's got to go and everybody's got to get the sack and blah, blah, blah. Somehow or other, we've got to recruit these people to come in and do a very sensitive and difficult job.
To be clear about our capacity problem here, if you look at a whole series of acute hospitals, 45% of the patients who are sitting in the beds do not need to be there.
That's right.
And so on the one hand, you're saying, we've restricted the number of G&A beds and so on. But a system is absolutely sclerotic and not working. If that person is sitting there, they're deteriorating. The skill sets of the people around them are not able to do anything for them. In fact, they're going the other way. So this is about flow.
It is, but it's about a mindset change to say we're proactively going to look after that cohort, which will bring in a very different discussion, which is the boundary with social care. And so that really matters. But all I'm saying is we haven't got the capacity because we've cut it in part. And by the way, we cut it partly because of austerity, but actually we cut it because the senior medical establishment, I'm going to make it up 25 years ago, said we're going to be good at prevention.
We knew back then that there were going to be more and more people with multiple long-term conditions. So the demand thing was absolutely clear, right?
So why did we cut the beds?
Well, I think one of the reasons that we cut beds
it was length of stay.
Could reduce length of stay and therefore get more
and
people.
And we've got one of the most efficient, lowest length of stay of any system. So we've driven that really hard and effectively by
That's done very well, but it's left us with the problem of the long stay.
But our population is up 15%.
But
Germany's up 2%. France is up 7%. We're up 15% in that same period. So did we understand population growth and the need to invest in the infrastructure, be it soft or hard infrastructure, that travelled with that bigger population and ageing population?
There is the capacity paradox, isn't there? The greater the capacity you create, the more you'll fill it up.
The M25 cars will come.
The solution here is not, I'm guilty of this as well. I used to think it's all about getting people out of hospital. It's not. It's all about stopping people going in the first place. Otherwise, you get the capacity paradox and you will never solve the problem. Right. The issue is about a complete rebalance of how the healthcare system works and putting a huge burden on primary care, which fundamentally only half of it's got any kind of infrastructure that you can expand. We have to change the fulcrum point of care, and that's a big task.
For me, I think the first priority step is to target the highest use population. It's about targeting. And if what we try and do is solve the problem for the whole population all the time, do you know what? We won't make any progress. So you have to go in priority order. What has the most benefit first? So for me, it's the enabling step that gives us a chance to do much.
And there has been quite a lot of work about how you identify them and what kind of support systems you get. I don't agree with you. There isn't a problem.
Just from the listener's point of view, Neil is pointing at me, Roy Lilley.
Yes, do be clear.
Pointing his accusatorial finger.
It is not just a question of reducing demand going into the hospital sector. That is absolutely vital. It's also
the enabling step.
The hospital sector is able to get people out. If you have a blockage and you're not able, even if you reduce the numbers who are coming in, if you do not have a means by which you can get them out, then that's...
Well, explain what I mean. If you're filling the wards up with people, then what do? You have more wards. Well, we pinch, medical beds go into surgical beds, and we stop doing elective procedures, or we put people in the corridor. Yeah. So then more beds is not the answer. You say, okay, well, more care homes will be the answer. We'll get people out quickly. So you fill the care homes up, and then it's more domiciliary services, and the domiciliary services fill up. That's the capacity paradox, which the NHS has never really addressed properly. And my view is the real issue is to stop people going into hospital in the first place. You won't stop it completely, and you won't stop. There'll be periods of filling things up, but we don't do enough, I think, in the primary care sector to try and enable that. And just to finish my point, I added it up the other day. I've seen, I think it's about 17 attempts to shift care out of hospital and to make primary care and be more efficient, do more, have greater capacity. I don't know what it is, whatever it is to do something in primary care, it always fails.
No, but so I think we have to be more optimistic than that. And I agree with what, Neil, you were saying. I know a couple of minutes ago about 45% of the people in hospital and so on don't need to be there. You know, whether it's that number exactly, I don't know, but it's a very, very significant number of them. And I know that the brilliant Chris Whitty is now uses the phrase quite a lot, I gather, which is that the majority of people in hospital are in hospital receiving basic nursing care, not hospital treatment. And I think in there lies the clue. And then to your point, Roy, I agree with what you just said as the analysis, but what I push back on is, do you know what? There isn't a solution which gets us 100% through it.
No,
Everything we do is about making an improvement, better than marginal improvement to the system
that's still a buckshot.
And so virtual wards, I think, are a real answer. And as I look at the initiatives with which I've been associated, the one that frustrates me probably the most is virtual wards. My appointment coincided with an announcement that we were going to build between 40,000 and 50,000 virtual wards. And there was a review after 18 months, and it was basically stalled. I'm a bit cynical. I think it stalls, one, because of money pressure, but also because I think it wasn't exciting enough as an announcement to say we've gone from 12,000 to 20. So we stopped at 12,700. But if you think about what a virtual ward is, it is a technological monitoring of either step-up or step-down care, often of elderly people. And if the readings deteriorate, we send out help. But we are shifting resource from our most expensive, extractive financial picture, which is a hospital bed, and we're shifting that into virtual wards and monitoring. And for either step-up or step-down care, whether 40,000 was the right number, but certainly 12,700 is not. And I think we should be going up to 2030 and see what happens. And I hope in the 10-year health plan that virtual wards will be a fundamental part of it.
But linked to that, and also linked to your work on workforce, is there a danger that we're fighting the last war all the time? So to what extent will AI, to what extent are we reinventing, say we want more doctors, more nurses, we want more GPs? Well, a GP is completely different. I know you've been saying how wonderful they are, but actually GPs are nothing like what GPs were even 20 years ago. So we've absolutely lost a whole series of things which people said were the most important things that GPs ever did, which is they know their patients, they know their continuity of care. And so we've moved on to something different. The nature of what those professionals all do is changing and has changed very radically. So the point where practically now a phlebotomist is about the only person who seems to be able to take blood from you. Other people, we've de-skilled people in one sense and specialized it because we've regarded the other things that they do. So I guess my question to you is, in terms of innovation, including things like genomics, new drugs and so on, often technology drives a whole series of changes. And we sit there and debate about how things should be organized and run and so on, and we ignore what is coming up on the right-hand side.
So I don't think we do. I mean, I think the NHS, and one of my frustrations in the narrative about it being broken, which I disagree with, actually is people miss how innovative it is. So we just had an announcement today in the newspapers, haven't we, about a new breast cancer drug been approved for the NHS. But if you look at innovation, AI, we're already using AI. So we use it in dermatology, ophthalmology, histology, we do breast screening.
In medicine, there's definitely enthusiasm about innovating and so forth.
Yeah.
You could argue that the system, I think many would say, constrains the degree to which they're doing it. On the other hand, the NHS had the dubious reputation of the biggest buyer of fax machines and has had enormous problems of trying to get its IT to speak to other parts of the system.
All I'm saying is it's too easy to attack. And actually, on the one hand, the NHS is much more innovative than the narrative around it buys the most fax machines. I'm not even sure if that's true, by the way. Is it true?
It was true.
Oh, it was true. Okay, let's keep repeating it then, because that's really helpful.
The NHS buys a lot of everything. There's like bog rolls and...
No, but I'm not being different. But can I answer the question? I started with innovation because I think people fail to recognise how innovative the NHS is. And it's one of my realisations. So you mentioned genomics, and we could go into that in more detail, but we think that in 10 years' time, 50% of treatments and interventions will either have some form of genomic testing or diagnosis as part of it, or some genetic or genomic treatment. given, which is revolutionary, where the NHS is world leading, amongst the world leaders. I don't disagree at all that the basics are under pressure, and the technology basics, and I hear it and I see it when you go on the front line, multiple sort of systems to bring up. But then I say, so what have we done? So the NHS app is absolutely revolutionary. Whether it's the number of prescriptions that are now being done automatically, you don't have to go and queue and all that sort of stuff. And the GPs have to sign them off in the same way. Brilliant. There's an argument you can start to see your appointments in secondary. You've got to be slightly careful. It depends which diary system the particular hospital trust is using, but you can see the potential. We've rolled out electronic patient records now. They're not good enough. And the next step, having rolled them out, is to get them connecting. And we're doing that increasingly. We've rolled out the Federated Data Platform to Palantir. It translates, and at the first time ever, the NHS is able in certain disciplines to aggregate data on a national basis. So it can see across every hospital, it can actually get the data interoperable. We get better positions and we're seeing real efficiency. We've got ambient documentation. When you see that, we think the estimate of a clinician's time that gets saved is 20 to 30%. And I think the NHS is making much better progress than people give it credit for, but actually society's expectations of immediacy are also staying way ahead of where the NHS is.
Richard, we're up against the buffers of time, unfortunately. But are you optimistic?
So I think what happens with the NHS, there's one big pendant, which isn't actually the current shape and the interaction with boundaries of social care and how fast we roll out technology and do we bring genomics in faster. It is actually, I think, a societal and governmental willingness to go at the causes of ill health. And the challenge of the NHS is we deal with whatever comes through those gates, whatever. So again, I'm often on the record to say we've just opened our 15th gambling addiction centre. We've opened our 30th centre in England to deal with severely obese children. So we are surfing on this wave of ever greater sort of illness. And some of the causes actually of that illness, I think, if I were West Streeting, this is rather impertinent of me, my health mission wouldn't have been the 10-year health plan. It would have been a call out for why don't we, backed by the Prime Minister, backed by other ministers, why don't we have an ambition where the UK becomes the fittest and healthiest nation in Europe? And the reason for that is it's not what the NHS does for you, it's actually what does everybody else do about trying to stay fit and healthy, which means, I'm sorry, minimum alcohol pricing. It means potential social media regulation. It definitely means you go after sugars and fats and ultra-processed foods. You know, we've got to go after those things. Otherwise, I think the way society lives is going to stay ahead of the NHS's ability. And if we don't do that, I'm not so optimistic. If we do that, I'm very optimistic. And I think what the last 3 years showed, and Amanda Pritchard and her team, post the pandemic, was actually steady operational improvement in every single measure bar one. So it takes time, but I can see a world where it gets gradually, steadily better. But the enabler has got to be actually what's the state of people coming through our doors, where the causes of what's causing them to come through lies outside the NHS's power. Now, I would love to be part of a society which says, one, we have a health system accessible to all, free at the point of delivery, regardless of your ability to pay, etc. But where actually we're in a mission where actually we want to be the fittest and healthiest nation in Europe, which means, come on, you food manufacturers, come on, you, whoever's selling the alcohol, we're going to have a very, very different approach as to what the UK is going to look like.
And on that optimistic note, I think we're going to have to do. Richard Meddings, I don't know where the time's gone. It's been really interesting to talk to you and to hear your views. And thank you for spending your time with us. Well, what do you make of that, Neil?
I think it's really interesting how someone who comes from another sector, some would say gets captured by it, but of course his mastery of the detail and his understanding. One of the questions I would have loved to have asked him at the end is, how is it that Amanda Pritchard and her team were described as being intellectually stagnant, and yet he is managing to sell them so well in terms of all the things that they've done, and they did them within a very constrained environment.
That was the PAC, wasn't it? But I mean, you know what select committees like. It's just MPs grandstanding, isn't it? I never saw them intellectually stagnant. I think
they've become victims, obviously, of a new government coming in.
Yes.
And a new government, I know you're very critical of it, but a new government is bound to say it's all rubbish and we are going to turn it around.
Yes.
We are going to
Well, I am critical of it. I'm critical of the attitude, and I'm critical of what they did to people's morale and how they insulted professional people. And that is not the way. I mean, look, maybe I'm just too old for this game, and maybe young politicians have license to be rude and insulting and behave like thugs. I mean, they all think they're Elon Musk. Perhaps that's the way of the world. If it is, Neil, it's not the way I like the world to be going. I think that I look back with some fondness on the days when politicians had some manners. Who are we talking to next? Have we got our next guest lined up? That it's somebody quite important.
I think we do have somebody quite important lined up. It's Jeremy Hunt.
There you are. It's Jeremy Hunt. So he's going to be very interesting to compare and contrast with what we've just had and see it from a minister's point of view.
Always interesting how people, when they're in office, are not able to say what they really think. You heard in the last half hour or so somebody who was able to say what.
Well, listen, if you're listening, well, of course you're listening, otherwise you can't be hearing me. I hope you enjoyed it as much as we did in doing it, and we'll look forward to seeing you next time, where our guest will be Jeremy Hunt. Goodbye from me, and
goodbye from me.